So it's 1:45 in the morning. I just scrubbed out of the operating room. Had to come in to deal with a patient that was bleeding. This is the challenge. I mean, one of the difficulties about being on call, being an emergency general surgeon or an acute care surgeon, means you're here at night. You're here in the middle of the night solving emergent problems. Sometimes people will say that's a negative lifestyle. I can understand that. But you know, I'm grateful for the opportunity to be taking care of people in the middle of the night when they need us the most. So there's a great reward in the work that we do when we come in the middle of the night and do an operation like this. So I'm grateful for that opportunity. But it can be demanding. We actually have 2 more surgeries tonight. I didn't expect to even have any operations. When I started this evening, everything seemed quiet. But we have 2 more surgeries to do. So probably another 3 hours. So it's about 1:45 right now. So should expect to be done hopefully around 5 in the morning. Hi, my name is Dr. Rich Hilson, and you're watching my channel, Knife Skills. Today, I am going to declare the greatest operation of all time, the oracle of operations, the supreme surgery. Today, you're going to get it straight from the horse's mouth. What is the best, most important operation of all time? Now, I know what you're thinking. What kind of criteria could Dr. Hilson possibly be using to decide what is the greatest operation of all time? Well, I'll tell you, if I were to choose the best and greatest operation of all time based on how many lives it saved, then I would have to choose the cesarean section or the C-section. Now, I'm not going to do that, but the C-section is a unique operation because it can save both mom and baby. Arguably, throughout history, when we've been using C-sections, we've been saving many, many lives. It also has an incredible impact on disability. So many children survive poor oxygenation, and the C-section saves them from that. So I'd say the C-section, really, from the number of lives saved, would be the biggest operation or the greatest operation. But I'm not going to choose that. Another criteria could be, what operation would we choose if humanity could only have one operation, right? If there's only one surgery you could choose to have, you know, cardiac surgery, gastric surgery, whatever it is, again, the C-section would be it. There's no other advance in surgical technology throughout history that has had a bigger impact than the C-section. So if I had to choose as a medical provider to only use one particular surgery, that was all we had available to us as a human species, I would definitely choose the C-section. But I'm definitely not going to do that either. No. I'm going to use other criteria. First of all, the coolest operation, I think, or the operation that people are thinking about when they talk about saving a life, someone coming to the emergency department, needing some emergency surgery and having their lives saved. I'm going to use criteria like that. And I'm also going to use criteria based on the fact that I do the operation. It's very important. I think if I'm going to pick the greatest operation of all time, it certainly must be an operation I do. And with that very rigid and objective criteria, I am going to choose the trauma laparotomy, of course. Now, this video is very similar to a video I did earlier where I talked about the resuscitative thoracotomy. My intro to that video really talked about how people ask me all the time, you know, what's the most crazy or intense or biggest operation that you do? And the trauma thoracotomy certainly is that category. But that operation doesn't save very many lives. There's very few people who survive a emergency department thoracotomy or a trauma thoracotomy or a resuscitative thoracotomy, whatever term you use to describe the same procedure. But the trauma laparotomy is special. It's a challenging operation that requires boldness to go and do, and yet has a very high survival rate and a very high save rate, in the sense that the majority of people who go on to have a trauma laparotomy absolutely need it. There's a very small proportion of patients who would survive or at least not have severe disability if they didn't have the trauma laparotomy at the right time. So I think it's a very important, and for me, it's the king of operations. And so that's what we're talking about today. I'm going to divide this video into 2 sections at this stage, just like I did with the thoracotomy video. And feel free to check that link if you're interested in it. I'm going to break it down in two categories. I'm going to break it down for the average person watching this video. Most people who watch my YouTube videos are not actually medical professionals, but are just kind of curious about what it's like to be a surgeon, what the life is like as far as being a surgeon. So that first half is for you. The second half, though, is for medical students. So you can skip over there to that time code in the YouTube video if you're a medical student and you want to learn more about how we do a trauma laparotomy, really what the technique is. So if you're a medical student or a resident and you want to talk about this procedure and you can describe it, that second half is for you. So what is a trauma laparotomy? Well, the trauma laparotomy is a unique operation. First of all, one of the main things about the trauma laparotomy is that it gives you access to multiple cavities in the body. So, for example, when we're operating, we have the thoracic cavity and the abdominal cavity. Now, the lower part of the thoracic cavity is available as part of the trauma laparotomy. When you make a generous midline incision that accesses the abdominal cavity, but we can actually reach up and take a look at the heart, doing something called a subxiphoidal window is a way we actually get into the chest and examine the heart from the belly. It's a great operation. Also, that operation can be extended. You can add incision into the thorax to do a sternotomy, and that can give you access right from the bottom of the pelvis here, right up to the clavicles. So it's a really great operation to access the abdominal cavity, as well as the thoracic cavity and the pelvis. And as a result, there's so many different organs that you can access. There's so many different organs that can be injured in that cavity. You have the spleen, you have the pancreas, you have the stomach, you have the intestines, you have the great blood vessels, you have the liver. There's so many things you can access from the abdominal cavity. And there's so many target-rich areas, as we say, so many places that can get injured in trauma. So the laparotomy gives us access to that procedure. So how do we decide to do such an operation? And that's an interesting question because that's where surgical judgment comes into play. We all know that not every person who's involved in a car crash or stabbing or even a gunshot wound requires surgery. Many do, but many don't. And so typically what we do is we look for signs of internal bleeding. Now in 2022, that's typically done by taking an ultrasound, just like you would for evaluating a pregnancy. You take that ultrasound, you can examine the belly and see if there's fluid in it. And usually in the context of trauma, fluid represents some blood. Now you add the fact that there's bleeding internally to some sort of change in the patient's vital signs. So a patient who has a little bit of bleeding internally, but their heart rate's normal and their blood pressure is normal, those patients typically don't need surgery. We can use what we say non-operative management or observation to get them through that trauma. But if they have an abnormal heart rate, abnormal blood pressure, and they have bleeding into the belly, that would be a strong indication for surgery. Now, where that threshold lies will depend on your hospital and your institution. So some hospitals have excellent access to interventional radiology and have great trauma observation centers and may not need to actually go to the operating room on every case. They can use those other techniques. On the other hand, other systems might have different levels of access to interventional radiology. They may have different types of observation teams and observation units. And so that might require that particular center to choose to operate more on these types of cases. So that's sort of a nutshell indications and what we're doing in the trauma laparotomy. So now let's move on to the more technical parts. This is where we're going to talk to the medical students and the residents. And we're going to go kind of top to bottom on how you do it so you can describe this procedure on your exams, or if you're explaining to a colleague, or if you're talking to a senior about how to do the trauma laparotomy. So the first step on any surgery is thinking about positioning and prepping. So for the trauma laparotomy, we want to have the neck to the knees exposed. You want to have the arms out so that anesthesia can get access to the arms to give drugs, blood products, evaluate the patient, determine blood pressure, all of those factors. We want to take our prep and we want to prep from the neck all the way down to the knees. And the reason why that is like I mentioned, you may have to actually extend your incision up into the chest depending on what you find in a trauma laparotomy. That may even have to go all the way up into the neck depending on the type of injuries that are there. You also want to have access to the knees because there are times when you might need to actually get a blood vessel down in the leg, maybe harvest that blood vessel to repair something else, or maybe an injury in the lower abdomen extends down to the leg. You'll need access there. You may need to get access here in the groin. Sometimes we put balloons up into the aorta to help deal with blood pressure. There's lots of reasons to have access down below. So the first step is draping and prepping. Then, of course, you're going to do your surgical checklist. Those are very important. And then you're going to make what we call is a generous midline incision, essentially from the xiphoid sternum all the way down to the pubic symphysis. When you're doing a proper trauma laparotomy, you want to use a large incision. You don't want to use these smaller incisions. These are other types of laparotomy incisions, depending on what organs you're accessing. But in trauma laparotomy, you want to make a big incision. Once you get into the abdomen, you start packing with sponges like this. And we pack 4 quadrants. We pack in the right upper quadrant above the liver, pack around the spleen, and into the pelvis as well. Once the packing is in, then you evaluate the intestines, looking for any bleeding in the mesentery, that's the blood vessels that go to the intestines, or any injuries to the intestines themselves. You might stop the bleeding with clamps. You might oversew a hole or put a clamp across a hole so that it doesn't have any more contamination. Then you go to your sponges, see what's red, see what's not so red, and you're going to evaluate each organ system individually, the spleen separately from the liver, separately from the pelvis, and that will help you determine where the predominant bleeding is coming from. Then you're going to deal with the specific injuries that you see. Now, in a trauma laparotomy, this is a critical point. Do I complete the laparotomy or do I do it in a staged fashion? So staged trauma laparotomies are something we call damage control surgery, where we stop the operation in the middle, put in a special kind of sponge around the abdomen, the skin is open, the abdominal muscles are open, and send them off to the ICU for ongoing treatment and resuscitation. The reason why we do this is that the patient may be so sick that more time in the operating room can actually cause more problems. They might lower their temperature, they might bleed more. There might be all kinds of changes to the physiology that happens in the operating room. So we take them to the ICU and continue our gentle and balanced resuscitation before we go back to the operating room at another time to complete the operation. So that will depend on the patient's physiology. It'll depend also on the types of injuries. Some injuries are maybe beyond your skill level as a surgeon to repair. You might need a subspecialist to help you. And that would be something like certain types of pancreatic injuries, maybe certain types of vascular injuries, maybe certain types of thoracic injuries. It might be a number of reasons. So you might bring a colleague in to help you deal with those specific injuries at another time. So that's what we call damage control surgery. So if you don't do damage control surgery, you're going to complete your operation, you're going to close the abdomen, close the skin, and then you're going to send them off to the recovery unit or the ICU, depending on what the patient needs. So that there is the trauma laparotomy in a nutshell. Certainly the operation that I think is the greatest operation of all time, the mother of operations, the king of operations, as you might say, the trauma laparotomy. I want to say thank you once again for watching. I appreciate your comments, and really, I've enjoyed connecting with people through the comment section. So leave a comment below. Also like and subscribe, of course. Everybody who's on YouTube wants some of the commitment from the audience, so I appreciate it. If you're interested in this video, you may be interested in to watch my video, Crack the Chest. I'll place that over here. It's a fun video about the trauma thoracotomy, which I mentioned a few times. And if you're interested in any more of these types of videos, I'll have a playlist, it's a small playlist called Mini Med School, where I talk about a few of the medical school lectures that I've done in the past. Once again, thank you for watching. My name is Dr. Hilson. You've been watching Knife Skills. Have a great day.